Sorry, cut that part out, guys. So, hi, everybody. I'm Rajan Roos. I'm the CEO and founder of the San Diego Pain Summit, and I am here with a special guest, Amy Eicher, who she's an author, speaker, and pain coach, and she combines her 20-year-long journey through pain with her love of learning to help others use their own complex stories to recover from chronic pain. She's also the host of Restoring You, a podcast that shares health success stories and draws on her experience as an educator and youth ministry leader to provide dynamic public workshops for clinicians and their patients. She's also a graduate of the Illinois State University in Normal, Illinois, where she lives with her 2 children. And she's also the author of Restoring Venus, which I had the honor to read just before it came out. And it was just an excellent book that described Amy's journey as a hopeful Olympic swimmer to experiencing pelvic pain that just left her debilitated for many, many years, and also inspired her to become a clinician, which she is now. So it's a pretty unique journey. And, you know, thinking about that, I'm curious, like, now you've, as a lived experiencer of pain that you are living with, and then also a clinician, what is something that you've learned from that process that you really wish other clinicians could understand, since you've been both a patient and now you're a clinician?
I think well, first, thanks for having me. Like,
oh.
This is really fun, and I'm excited. And that was like all the nice things that you just said, so thank you. And I really was honored that you read the book before it came out, so thank you for that.
It was, and I just want to throw a quick little other blurb about it. Not only was the story very intriguing, but you are also a talented writer. So I was a little nervous to read it because I wasn't sure, it almost seemed like it might be a chore. But then as I read it, I couldn't put it down because you have a talent with writing. So it was very easy to read. I sat down and read it, and I read it like through beginning to end. Anyway, I just wanted to throw that in there too.
I've had a couple people PM me and say, it's your fault I didn't get any sleep last night.
Yeah.
So they read it all night long, which was really, that's really exciting. So thank you. So my bizarre combined experiences of 20 years of pain and education, and then my degree is a Master of Arts in Religion, which was really a ton of psychology and a lot of like self-exploration, because in ministry they don't like to like send you out to work with people that are broken without knowing yourself. Like, they're really big on that. And then my journey as a clinician, learning about the anatomy of the human body. So I've got this piece of how do we teach and how do we learn? And then I've got this piece of self-exploration and dealing with beliefs and others' beliefs, and how do you create a space where you can talk about controversial things with people that maybe don't believe the same thing that you do. My personal experience with pain, which 20 years of pain is kind of hellacious. Let's maybe try to cut that down for others. And then, as I said, the biology. So when I mix all of that up in the soup that is me, I think the thing that I see lacking in our clinician to clinician discussions is the ability to create that space to hold your hands open and have constructive conversation when you believe one thing and I believe another, and research says it has no idea which one of us is right. And a lot of that has to do with sitting down and kind of peeling away our own layers and learning why we hold on to certain things so tightly and why we don't really care about other things. Like, it's easier to hold that with an open hand and not be so, but this is me, or this is my thing, or whatever that attachment is that causes us to be passionate. There's nothing wrong with passion. There's just, I think we need to know better in and of ourselves where that passion comes from and why we're so connected to those ideas or theories or treatment styles, I guess, maybe.
So it sounds like you're talking about As you know, and I was a massage therapist for 16 years. And as I mentioned in another discussion, there was a time that I had an opinion about, say, CrossFit, right? So when people would come in and tell me they were doing CrossFit, I caught myself bringing that into the clinic and like judging them to want to say, don't do that, you're going to get injured. But I caught myself and stopped myself, and it was more like, okay, well, it's nice that you're doing something, but I would still have that, that thought that I obviously was biased against CrossFit for a while.
Right. And I was as well. And I felt like there's the conversation that happens in the back of my head, and then there's what actually comes out my mouth. And hopefully I've checked what's going on back here before I let it.
Just sometimes. Right.
Not always.
Yeah, sometimes it works.
Or at least that I could tell you why why did I not like CrossFit? I don't know. It just sounded hard and scary, and like dumb things might happen. And then I was exposed to it, and then I was like, oh, this isn't dumb or scary at all. I should probably check that. Mm-hmm. And it just came from not knowing.
And you saw a lot of that, when you were going from clinician to clinician, and you were seeing a lot of healthcare providers because you weren't sure what was going on, and nobody could give you a clear answer until I believe you flew across, like you flew further east to see a physical therapist who finally was able to help you. And I guess you probably saw a lot of that, right? Where clinicians were bringing their biases into the office, and
and how that affected me. Well, and I love the idea of anchoring bias for a patient or a clinician even. But
and can you give the definition for that for the?
I think I can. Basically, the first idea that we hear is kind of what we hold on to, and that becomes the basis from which we operate. So for me, I had SI joint pain, and the first reasonable explanation that was given was that my pelvis was out of alignment and I had snapped my SI ligaments, and so it was never going to hold again. So this is the picture that I have in my head. This is the narrative that I have in my head. And when I would encounter people that did not share that narrative, I would dismiss them. Well,
so they literally told you that it would never, they just snapped off and you would never.
Yeah, my core would need to be strong for the rest of my life, where I would always have pain. And clinically, we know that there's some problems with that story, like a lot of them. But
it still said a lot.
It still said a lot. And the lack of imaging that could corroborate the snapping of these SI ligaments, was a portion of the problem. The testing used to determine it, as well as, the positional issues that, we can't really check that out so great.
Yeah. unless you're a yoga master, maybe.
Unless you're a yoga master, or you've got like
with a microscope, I guess.
World, I don't completed level 800 of somebody's class, but it took 20 years and a lot of failure to have my beliefs challenged, where I finally came out to a better understanding of why those explanations don't really hold a lot of water. But the journey to surgery for me, like if a clinician did not validate that belief within me, I dismissed them. They were stupid. They didn't know. They were uneducated. Because most of the time, I wish I could go back and find those clinicians now, but they just kind of rolled their eyes at me and they were like, yeah, that's not really what's going on. They were right. They were right, but they didn't really offer an explanation. And I felt so dismissed by their body language, by their facial expressions, that I couldn't connect. So somebody that really, really, really could have helped me, I walked out the door because within that first few minutes, I felt dismissed, whether they intended it or not. And I think that's a perfect example of where my beliefs and their beliefs didn't match up. I am happy to say today, they were right, I was wrong. But I never gave them a chance to explain their story because of the body language that came with what I was hearing.
Yeah, and that's interesting. Greg Lemon he touched on that in his 2018 presentation at the summit. And somebody in the audience had asked, well, what if your patient comes to you, but they believe they believe in that structural problem? How do you change their mind? And his response was just say, okay, yeah, that's interesting. So here's what we can do,
Yes.
which I thought was a really great way of not, because obviously you were coming to these clinicians who knew that that wasn't really the truth,
Right.
but they obviously that set them off too. Like they were like, oh, I'm not going to be able to change this patient's mind.
Right.
And then maybe that's also the barrier that you were feeling on top of experiencing this unnamed pelvic pain.
Right. Or it had been named, but it wasn't solved anymore. Like
Mm.
all of the solutions were no longer working, which in my head meant, the ligaments were looser.
So, speaking back to those clinicians that were like, that's not really what happens. Do you think there's anything that they could have said or that they shouldn't have said that would have made you, considering that you had this anchor bias that, of course we all have and we can't help it. But for those patients who have that anchor bias, they already believe that this is the cause. What is something that could have happened in the treatment room that would have made you want to listen or at least stay for the appointment? Or
I think a comment like Greg's would have been helpful, where
mm,
my story was acknowledged, like just acknowledging, as wrong as it was, acknowledging that, like, I mean, we're talking 10, 15 years into the belief of this story. Like, you've got to meet me there. You got to meet me there. And I think looking at my story, the things that really helped me personally and my makeup of things that move Amy along in life, I had experiences that didn't make sense with the narrative, but nobody bothered, like nobody drove that home. They just kind of let it sit there and let it
can you give
percolate.
an example?
So if my core needs to be strong and I'm supposed to like not do asymmetrical things, right? Because asymmetrical things are the bane of the SI joint. We shouldn't do them. Never do lunges. It occurred to me one day that I did asymmetrical things all the time, like walk upstairs. So
Mm.
lunges hurt all the time. Walking upstairs didn't. Okay. Walking is an asymmetrical event. So if I'm supposed to avoid asymmetrical things, am I really supposed to avoid walking? And like the absurdity of that struck me one day.
Mm.
That makes no sense. If I don't have pain when I walk upstairs and I don't have pain all the time walking, maybe asymmetrical things are not that bad. So what else could be happening? And then I think it was at that point somebody pointed out, hey, fear has like a pretty big effect on our pain levels. And I was like, oh, lunges scare the crap out of me. Yes. Like there is palpable anxiety that happens when somebody asks me to do that. Maybe I should figure that out. And then breaking that down to much, much smaller things where, like I lunged into a step because that was more like taking a step than doing a lunge, and that was fine. And then it was like, okay, well, what if you did like one lunge, just one? Can you do one? Yes, I can do one. And then we let it go. And then I tried two, and two was fine. But so breaking it down where the absurdity of the statement kind of percolated to the top. And I think more discussions with me in clinic versus just more planks would have been a really, really good thing at helping me to explore my movement.
Mm. Yeah, that's a really good suggestion, because it sounds like in order for us to overcome our biases, these are personal incidences that happen, like what happened to you. And it's why it sounds like we can't convince people of stuff. They have to figure it out for themselves. And I like that about exploring movement.
I'm a fan of the well-placed question too. Like
Mm.
that as the clinician, we don't have to answer. You just kind of like deliver it. Like something somebody could have asked me was, do you think all asymmetrical motion is unsafe? Or that you
Mm.
should, and then just let it hang out there. Like you don't need to give me a lecture on it as the clinician. Just leave me to walk away with it.
I
And then
see. So kind of asked like like kind of an open-ended question to lead to that discussion, but don't be attached to seeing that discussion through, is what it sounds like you're talking about.
because some people can answer immediately, like their brains just work like that. You hear a question like that and all of a sudden you want to start playing with the pieces. Other people need time to like think about that, and it's threatening to try to have that conversation right then in that moment. So if your person starts talking, great, go with it. If they don't talk, check with them again next time. Did you think about that? And if they didn't, find something else.
Yeah, and some people are just not going. I had a client, as a massage therapist, we don't use the term patient in the US, we say client. And I had a client who, she dealt with chronic back pain, low back pain, that she lived with and she was, okay with, but it was just always kind of there niggling at her. And but she was a firm believer of the structural story, of that structural narrative. And I never tried to ever talk her out of it, or I would just do things and she never seemed to wonder like why that helped. And the structural narrative work didn't help. We just never went there. And she saw me regularly for years until I shuttered my business. But she was probably the only client that I had that just never, she just wasn't interested. She had her belief and that's what it was. And I just worked with that. I never,
And
try to argue with her or anything like that.
I think, and I need to listen to my own advice, but I think that's often the way that we
We
should,
give the best advice to other people, don't we?
right? And I know I'm guilty of that as well, because I'm one that wants to understand the whys behind everything. Like everything in the world, I want to understand why it works. And not everybody's like that. But if we can get our people moving and feeling better, even if they've got the science wrong, does it matter? Like, I get that it matters to us, to those of us that like pick it apart and tear it apart and read the research and comment on the research. And I mean, you and I are in several wonderful Facebook groups where we're happy to do that literally all day. But I think what's important to the person in pain is, I want my life back the way that I want my life, not the way you want my life, not the way my doctor wants my life, not the way my mom, dad, brother, sister, kids want my life, but my definition of what it means to live well. And I may have been in pain so long that I literally don't know what that means anymore. Like I may be having a complete and total identity crisis. So the fact that you don't think my SI joint is out of place and you think it may have more to do with like the stress of my family, great. How do I move? Like, and the stuff that's like super interesting to us becomes completely irrelevant to the patient, client, or otherwise, whatever you call them, the person in front of you that needs help.
So are you in clinical practice right now?
So I am, yes and no. I work for myself as a pain coach, so it is not under the moniker of PTA. So I coach people online through Zoom calls just like this. And I miss being able to like hug you and touch you and tell you it will be okay, but I do the best to do that with my voice. And
So I'm curious, so when you have somebody come in, just as an example for those who might be watching, like what that looks like, where somebody comes to you and they're in a lot of pain and they want their life back, even though they're probably not going to ever really actually get that same life back that they had. What does that discussion look like from your perspective now with your clinical background when someone comes to you and maybe they have that thought? How do you draw that out from them, and then how do you work from that position?
that's a great question. So the very first session is scheduled for an hour, and I have never finished in an hour, because the first question I ask is, tell me your story, and I let them talk until they are done. And it is not uncommon to have somebody talk for 45, 55, 60 minutes. Just telling me, you know, and I think the longer we've been in pain, the longer our stories are. But they get a sheet up front with a lot of questions in it to get them thinking so that we can talk through some of those issues. So the sheet addresses the what fors and the whys. How did the pain start? And then what was happening around the time that pain started? Because I want not only the biological, but I want what was going on in your life at the same time. And the stories that these people share it's heartbreaking. It's heartbreaking to hear of the medical neglect and how nobody will listen, and how I just got put through this program and they didn't seem to care that it wasn't working. Like, and to me, that's just all lack of critical thinking. Like, we've just stopped thinking in medicine in a lot of places, and that burdens me. Like, I want that to be different, which is why I started practicing. So after listening to all of these, you know, all of the story, my next question is usually, what is the one thing that you want back? What is the one thing you wish you could do? And I think one of my favorite answers has been, I wish I could sit for 35 minutes so I could have a cup of coffee with a friend.
Mm.
Well, that doesn't seem like an awful lot, does it? I mean, it's so deep and impactful that they're asking for connection and relationship, and being able to socialize is really what they asked for. And what's limiting them is the inability to sit. And she could only sit for about 60 seconds before her pain increased. So we used graded exposure, so I said, okay, so don't sit. Like, she was sitting to try to talk to me, and I'm like, lay down. I can lay down. Yes, of course you can lay down. You can stand up. You can do what is ever comfortable for you. You're in your own home. So a lot of permission giving to do things that aren't normative, right? So much of my time in pain was trying to look like everybody else at the cost to myself. So whether it was doping myself up on tramadol to go to the kids' thing, or pushing through pain because my experience in athletics was no pain, no gain. Pushing to be normal. And I think that's a pretty common cry of people in pain, and you get to the point where you just can't be normal anymore. And so giving permission to not be, because what you're experiencing is common, but it's not normal. You know, it's not acute pain. It's not pain that says, hey, there's a thorn in my foot, I should take that out. You've taken the thorn out and you're still in pain. So lots of permission to lay down, permission to go, permission to not go to XYZ, right? And I think what I've learned with all of my schooling and my experience is people really do know what they need if we listen.
Mm.
So I've had to unlearn a lot of what I learned in PTA school about listening for keywords to be able to diagnose, to bring back to the PT. Push that aside and just listen. And I think that's one of the hardest things as a clinician to do, because we are cramped on time and we've got to write it down for the insurance. And like, there are all of these factors working against us to be actively listening to what our patients are saying. But they're telling us over and over. Like, I mean, they're literally repeating it in 100 different ways. They're telling us what they need, but we're so busy being prepared to give advice or to write the note or to do the next thing, or the next patient that's coming that's like got their 4 kids and they keep bringing them, and what are you going to do with them while you treat the patient? You know, like, there's so many limiting factors. So I listen, and I listen to what they're telling me they need. I give permission, and then we come up with a simple plan to deal with that one thing. And that's like the thing. So if we're, any exercises that we're doing, any practice that we're doing, I mean, with the chair thing, like with the not being able to sit thing, her first assignment was to sit on every piece of furniture in her house for a minute. And take as much time as she needed in between. And to find out,
clever.
Right? Is there one chair that makes you happier than another? Like, is there a place where sitting for that minute was comfortable. And I think she said by the end of the day, she'd sat for like a total of like 20 minutes because she sat on each cushion of the couch. God love her. But she was so excited that, you know, in one day she'd sat for 20 minutes. That was more than she'd ever done. And the weirdness of sitting on every piece of furniture. Like,
but you encouraged her to explore movement.
I did.
Which is, that's a really clever way of doing that.
Thank you. And so a lot of my homework assignments are really, really bizarre like that. Like, you know, go to a furniture store and pick 5 pieces of furniture to sit on that don't look scary. Because, don't tell. They also had to get in and out of the car, and they had to get to the place, and they, you know, how long did you spend sitting today? How did it go? I learned I could sit for 5 minutes on this piece of furniture. So I came home, you know, so then can you try sitting for 5 minutes at home on that one piece of furniture that you absolutely loved and adored? Yes, I can. And then it becomes a prescription. Like, we find the tolerance, and then they negotiate with me how much they think they can go up by. And if we get to a point where, okay, well, I sat for 7 minutes and that was too painful, but 6 was okay, then we go back down to 6. And then we go to 6:30 instead of 7 or 10. And I just keep working things that way. And
I love how you put that you let them negotiate with you. I think that's a powerful statement right there, I think.
Because I think it's easy to say, okay, we'll add 5 minutes every 3 days, right? And then I'm in control of what you're doing. And I don't know if that's freaking you out. Maybe that's too much. Like, maybe that's too much emotional load for you. So the sitting isn't going to go well, and it's not because your butt can't tolerate it. It's because your brain can't.
And it's interesting. I just want to touch back on what you were talking about, giving permission, because it reminds me of, and it's also at the forefront of my mind right now because I just saw it on Twitter. A clinician had a stack of books for their library, and everyone's like, oh yeah, let's start a book club and all this stuff. But one of the books was called The Culture of Pain. And I can't remember the author, but it was recommended by Barrett Dorco. I remember like 10 years ago on Soma Simple. And anything he recommended, I read. I purchased right away and read. And it was very interesting. And it was about how much our culture influences how, you know, our life. And when you're talking about people not needing that permission, like your patient needing that permission to lay down during your call, she didn't think about it. That's how powerful our culture is, that we're trying to, you know, do what we're expected to do. So that was a very interesting piece that you were talking about right there, I think.
I thank you for lifting that up. But I think that's a place where, you know, the Jolettas and the Amys and the Keiths of the world, and the Petes, can't forget Pete out there in the UK.
You better not.
Right? Sorry, Pete. That's where those stories and the willingness to like lay our lives bare and say, just dig through this rubble and see what you can find, and let's talk about it. Like,
and just to interrupt real quick for those who are listening, Joletta Belton and Keith Waldron are really involved in bringing the patient voice into discussion about pain. And then also Pete Moore is in the UK, and he's developed a program to help patients learn about managing their pain, and also clinicians to learn how to work with people in pain. And so those are the names that that Amy referenced earlier. I just wanted to throw that in there so people aren't like, huh?
and those conversations are so important, because I think like the patient and the clinician in me battle a lot, and I find that particularly interesting because I know what it's like to experience the pain, but the clinician in me is so driven to give answers and to provide help and to do these things that as the patient I know are not helpful. So if it's that hard in me, I can't imagine what it's like to not have this like dual persona battle.
How do you manage that? Like, how do you?
So when I recognize that I have injured a patient emotionally, I've not listened. I've like, because you can see it in their face. It's immediate. If you're paying attention, you can see it. You see the recoil. You see the like shutdown that starts to happen. And I will have a conversation with the patient. What did I say? I'm sorry. I see that I've hurt you.
Mm.
And I
So as soon as you see that, you get that sense of that shutdown, you address it right away.
And that's part of my personality type as well. But I address that right away, and I say, I apologize. It seems that I've done something that has hurt you, because I don't want to tell them how they're feeling either. And I will take that after the appointment and reflect on that. How does what I believe about pain, or the way that I address pain, or the way that I think a patient needs to move forward, like, it's always an I statement. What I was thinking something that didn't meet what the patient needed.
So I am wondering, when you do say that, when you do address that, you see that block, you address it, what are some of the responses that you hear from the patient?
The most common thing I get is crying, because
Oh,
nobody has stopped to apologize.
wow.
Yeah. And then I'm kind of like shaken, right? Because I'm just trying to be human and acknowledge that I've wounded you, and I've wounded you with my words, and I did not mean to. Like, I meant to help. So allowing them to have that experience, and then usually it's a very simple and short conversation that says, well, and it's enlightening too. My mom used to say things like that. I had a boss that used to, like, it's connected to something for them. And maybe those words were perfect for the person that I talked to before, but it wasn't perfect for this person. And so they give me the history behind why this hurt. And it usually enlightens things that we're working on as well.
Yeah, that makes sense, because I know one thing I've learned in life is not to take things personally. So if somebody immediately doesn't like, we can tell if somebody doesn't like us or whatever. And I used to take that personally, but as I get older, I realized that I am reminding somebody of somebody, right? So I'm reminding someone of someone that they had a problem with, someone they don't like. And I have also experienced that, where somebody reminds me of somebody I may not have gotten along with. Fortunately, I can see that, because, I like to question everything. Like, I'm with you. Like, some people, like, I think some of us are born with what I like to call an engineer mind, where we're just curious how things work. And then others are they just don't have that curiosity, and that's, fine. But I think that's an important thing to touch on. And I love that question. I love that you address when you see somebody put that wall up. I just think that's really a powerful question that I think probably would be more helpful, it sounds like, for other clinicians to adopt that habit.
It will be unusual. I mean, they will be unusual if they choose to do so. And I hope that they do just maybe have tissues in the office.
And it feels like a very uncomfortable question to ask.
Mm-hmm. Because as the asker of the question, you have to be willing to bring all of your walls down and be prepared to receive whatever the person is going to tell you.
And it also seems like it goes against our culture. Right. So when we see like this behavior that's not, that does shut down, it seems like it goes against our culture. Like, that's such a, like, to address somebody's subconscious behavior that we've picked up on. You just don't do that.
No, we're definitely not supposed to. And sometimes the person isn't even aware of it, but like when you call attention to it and give them a moment, right? That pregnant silence, they usually come back with, that did hurt. Can you tell me why that hurt? Da, 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 da. Or, no, I can't. It just did. Okay. Then I'm very sorry that I hurt you. That was not, I did not intend to, but I recognize that I did. Is there anything I can do to make that right? And usually they say just acknowledging it. I mean, thank you for acknowledging it. Let's move on. How do I sit? How do I kickbox? How do I, what's the next thing? But it maintains the openness of the relationship that, we keep talking about being interactors and not operators. And like, I think that's a huge piece. Like, we have to apologize and acknowledge the emotional relationship that we have with each and every client that walks through our door, as well as our responsibility for exploration of movement and all of these other things. And doesn't make us psychologists, but if you wouldn't treat your parents or your kids or your spouse, you know, what you would do to them, you should do for the other people that you interact with. Like, if you're going to take the time to explain or to apologize, I think we should do that in clinic too.
Mm-hmm. Yeah, and I listened to there was a little mini conference addressing the opioid issue, and it was sent live, and it was like President Clinton was part of it, and then they had a couple physicians, and one of the physicians, I was surprised to learn this because of course I haven't gone through medical school, but she said that part of the problem is that in medical school, they only spend, I think, 5 hours on pain. Like, it was unbelievable.
Wow.
It was such a small, and that's why she said, that's why we don't know how to work with people in pain, because it's just, it's a minuscule amount of their training.
Wow. That's a startling fact.
Mm-hmm. And now that you've been through physical therapy program, what was your experience with that?
I would say we had like 3 days on pain, really old pain theories that are, were already disproven by the time we got to them, which I may or may not have, shared in class.
Were you paying attention to that part? Or did you just like, whatever?
Well, I was really excited for that part because I was like, yes. And then all of the stuff came out and I was like, we don't have pain signals. That's like, cool. You don't want me to talk again? Okay.
I will say there is some hope because I have learned that there has been, it's been pushed into legislation for physical therapy training to start including that more, but it's probably going to be a few years before it becomes a requirement from the schools. So that's a good sign.
It is good. And I went out of town for my PTA program. There's a local one, and like they are using Adrienne Lau's book, Why Do I Hurt? Like to educate their students. So that was really encouraging. Having students from there was like a breath of fresh air. I was like, wait, you recognize what I'm saying. This is so exciting. So
there's no pain signals.
Right. No pain. You want to talk about nociception? We can do that. But it was nice to see some of those younger PTAs trying to like figure out how to incorporate some of those ideas as they worked with patients. So I'm not hopeless.
You're like, yeah, I'll just leave that hanging there.
Editors can do without what they wish.
No, because it's part of, I think one of the presenters, I can't remember at this last summit, and they were talking about weight count, I think 9 seconds or 12 seconds. I don't remember the exact number, but wait so many seconds and count before you speak. And what's really interesting is how difficult people find that to be. So obviously it is a problem that we have.
And it's not just in the clinic, that's just a people problem. That's just people and culture. It's not limited to medicine. It's, universal. We want to be heard. And so when we're aware that we, the human, want to be heard, if we can turn that around and say, okay, well then my client would also like to be heard. What can I do to facilitate that? How can I make them feel the way that I might want to feel? Instead of let me fix it and let me, everybody that goes into medicine, I think, is so well intended. Like, we want to help. Like, I'm certain if we did personality studies, there would be a trend. I think sometimes we get in our own way, kind of like a puppy with really big feet, and they just kind of trip all over themselves trying to get from point A to point B. I know that's how I feel as a clinician a lot of the time. I'm like, but wait, I'll just sit back. I'll listen. But like, I have to sit on my hands and I have to like actively think, shut up. Like,
yeah, you had to become comfortable with that.
Yes.
Right?
Right. And it was easy to listen to high school kids talk about their problems. I have tons of practice just listening. But gosh, when it came to somebody in pain, I've got all this cool stuff that I just want to share. And then I'm not waiting to find out if that's actually relevant for the person in front of me. And so pulling myself back and saying, Amy, wait. Amy, listen. Amy, be present. Like, there's a constant conversation in the back of my head reminding me to just keep my mouth shut.
So it's not easy. So for those of you watching who recognize that this is a problem that we want to change, it's not going to be easy.
No,
it's normal that it's not easy.
It's normal that it's not easy. And then, you know, for me, I had to look at, why isn't it easy? Well, I get stuff from you learning. I like to teach. So that's a positive for me. I get yummy endorphins and serotonin comes pouring out and all kinds of happy brain things happen, right? So like touch therapy, I love to touch. And at one point I realized in my practice, I was literally touching everybody. Did they need it? I don't know. I did. Like, I don't know if they did, but I did. Well, that's a terrible decision to make.
I was just about to say, isn't that antithesis to what we were talking about?
and it had to do with me becoming aware of the choices in my own practice, right? So am I speaking to be heard and to feel needed? Am I touching because I need touch? And we have permission as physical therapists and massage therapists and chiropractors and whoever else is listening to touch people. Like, that's part of our job. To teach people, that's part of our job. But do we know what we get from those things and why we're doing them? And does the person in front of us actually need those things, or do they need something else?
It's an excellent point. And I would love to talk to you for another hour because you make all these really fantastic points. But I'd like to end the session with what is something that, for those who are watching, whether they're going back to work over the weekend or they're just watching this on break or they're going to work tomorrow, what is something that a clinician can start doing right now that's based on what we were talking about today?
Sure. I'm going to ask you to practice listening and watch the clock and see how long it is before you talk. How long can you let your patient go before you feel that internal buzz to break in and say something? Like, just evaluate yourself and then decide what your next step is going to be. So that is what I would love to see people do for their practice.
That's great. Well, thanks again, Amy, so much for this discussion. It was pretty powerful. So if you need to rewind it and watch it again, that might be a good idea. But I really appreciate your time, Amy. And yeah, try that when you're with your next patient. Take a look at the clock and just see how long until you want to speak, until you get that feeling you want to speak, and just notice that. I think that's a really good habit to pick up.